Hello, I'm Sally Hogg, and this is the Mobilise podcast from the Centre for Research on Play in Education, Development and Learning at the University of Cambridge. Mobilise is a mini-series in which I talk to leading policymakers and politicians from across the UK about how research can be used in policy to improve children's lives. We'll be finding out about the things our guests have achieved for children and about the challenges that arise when trying to use research-based evidence in complex political environments. If you've got any interest in research, child development and children's policy, then this is a podcast for you. Today, I'm thrilled to be talking to Professor Harry Burns. Harry's Professor of Practice and a Special Advisor at the University of Strathclyde. He's renowned for his work on the link between poverty and ill health, and he's long championed the importance of action in the early years to address this link and improve lifelong health and well-being. Harry started his career in general surgery at Glasgow's Royal Infirmary before an interest in relationships between social deprivation and illness led him to turn to public health. Harry became Director of Public Health at Greater Glasgow in 1993, and between 2005 and 2014, he was the Chief Medical Officer for Scotland. During that time, he did a lot to support investment and action in childhood, particularly in the early years. As an academic, Harry continues to share the evidence that action in early life represents our best hope of breaking intergenerational cycles of disadvantage. Indeed, we had to postpone the recording of this podcast episode because Harry went to speak to the ministers in the Scottish Government. So, Harry, it's lovely to see you today. Thanks for joining us.
Pleasure.
You've had a hugely varied career and you've been a long-time advocate for children. Can you tell us a bit about what you've achieved and helped others to achieve? What are you proudest of in your career?
Well, I think the hardest decision I made in my career was to give up surgery after 15 years and move into public health. My surgical colleagues, I think, all thought I was mad. But it seemed the only thing to do because I was working in an area, the hospital I was working in was in a poor area in the East End of Glasgow. And I could see that the patients I was dealing with, they didn't need more surgery. What they needed was more wellbeing. And as I started to read about this, it seemed clear that either I should go into politics or I should go into public health. And since I'd probably rather have my eyes poked out than go into politics, public health was the answer. So that led me thereafter to begin to pull together the science of failed lives, if you like. Lives marked by failed education, failure in occupational attainment, and so on. And there is undoubtedly a science lying behind that, which I don't think policymakers have ever really grasped. If you know what the science is, you can come up with ideas as to how to fix it. And that's what we're missing just now.
And within all of that science, you're well known for advocating particularly for work in childhood. Can you tell us a bit about the particular bits of science that led you to focus on early childhood as a way to change some of that intergenerational cycle?
Yeah. The Adverse Childhood Experiences study published by research done in California related closely 9 different types of adverse event that children may have to failure in later life. And not just failure, but biological change in those individuals. And once you've got a kind of biological link between the experiences that a child had and the outcome of various parts of his physiology and so on, then that's you really got a profound link. So seeing that led us to start to explore studies that had been done in different parts of the world to try and see what they were saying about that link. And there is a consistent finding, which is where children are experiencing adverse events, there are a number of biological consequences that follow, and they're all bad.
So you talked about policymakers perhaps not having the understanding of the science that they need to grapple with the big issues that they're grappling with. What is it that you would really want policymakers to know?
It's not just policymakers that do that. I mean, you come across doctors that say that the link between adverse childhood experiences and failure in later life isn't proven and so on. Well, it is actually, and a number of different biological outcomes have been well documented. So politicians, unless they have some kind of scientific background, may not realise just the strength of the evidence around this. And if they did realise the strength of the evidence, they might then think that it's difficult to do anything to change the adverse outcomes. And, I can understand some of that, but, if adverse child... There have been a number of studies on the costs of adverse childhood events in different countries, and it runs into billions of pounds. It's really, really, because children who experience adversity in early life, they'll fail in education, they'll fail in the jobs market, many of them will go to jail and so on, and all of that has an impact on the economy. And so politicians need to make an effort to understand it, and they need to understand how you can reverse it. So that's what I would ask them to do, to engage with the arguments and then support interventions that may well improve the outcomes.
And as Chief Medical Officer, you obviously did a lot to communicate that science and make that case. How receptive did you find the politicians that you were working with?
I think I was quite lucky with the politicians that I worked with at that time. They were open-minded and so on. But it's not as if they could say, right, we're going to implement this policy or that policy or whatever. They did it quite a lot. Family nurse partnership, an early years collaborative, bringing people from different health authorities and so on together to begin to build up a positive response for children. So they did quite a lot, but certain things were missing in what we did. And one of the things that I regret hugely is that the data that was being collected, once people or the system stops doing things if they're not seeing data. And I don't think we did enough to collect data that would suggest that there was an impact of the interventions that we did. And that, I think, is a critical step that needs to be undertaken.
Do you mean in terms of data that is showing that immediate sort of impact of the interventions?
Yeah, I mean, it's hard in these circumstances to advocate for a randomised controlled trial, because if you have cast iron evidence that certain adverse experiences will damage the brain development of a child, then you don't want to be randomly allocating some children to having those experiences. So it's quite difficult to prove, but it's even more difficult to prove outcome if you're not collecting enough data to show a very clear trend. So health authorities, I think, run out of patience, if you like. Oh, we've been doing this for years and it's not made any difference, therefore we'll stop doing it. Children that are born today in 18 years' time will be starting to show the evidence of adverse events. So you've got to be patient and keep an eye on improving things. One thing that we did in Glasgow that I thought was quite powerful was we got community nurses in one part of Glasgow that was associated with a lot of poverty and so on, to write down the names of families that they were worried about. We then took that list to the A&E department of the local hospital and showed it to the nurses there, and they said, oh yeah, we know all of these people. They come here often. Showed it to a community policeman who said, yeah, I get 999 calls from some of these names. And we also spoke to local authority people about children being excluded from school and so on. We spoke to the housing associations, and some of their folks said, yes, we've been into that house or that house to fix broken windows and so on. You know, you can begin to identify families who are in need of some kind of support. But then, of course, you run into the difficulty of general data protection regulations. You know, oh my goodness, we can't share data for it with you. You know, well, actually, if you don't do that, some of these kids are going to die. So I absolutely abhor where we are with GDPR. It's responsible for damaging a lot of people because folk are frightened to share data that could help maintain their well-being. So it's that kind of thing that needs to be done, a focus on identifying the families and not going in and punishing those families, going in and saying, how can we help you? That's the key element in all of this.
Yeah. And it's interesting, isn't it? Because when you map exactly that story that you told, the state is spending a lot of money on those families, on picking up those pieces.
Oh, yeah.
And actually, if we could just use that resource better, we could really transform things.
It literally is billions, tens of billions in the UK. And okay, if we started an intervention system today, it would take 5 years maybe before we saw any substantial return, and then it would be another 20 years before we saw most of it being returned, because a minister a long time ago asked me, if we did this, would it work? And I said, yes, it would. How long would it take? I said, maybe 20 years, but by then you will be closing prisons. And he said, oh, right, that's the right thing to do. But, you know, as politicians come and go, and consistency in these settings consistency of policy is often difficult to maintain.
I wonder if there's something about, you know, that the economic case is powerful, but as you say, it's far longer than any political timescale, and so that doesn't necessarily drive an individual politician to make the case, because they're not going to see that. So, but you mentioned some of those politicians who did get the argument and introduce things like FMP. What do you think made the difference from them? What was the thing that really won their hearts and minds and made them want to take action?
They were clever, nice people. I mean, that's basically it. They cared, and they had the insight to realise there was science here, and that they could make people's lives better by following the science. And, you know, I would assume that all politicians are clever, nice people, but maybe I'm wrong in that.
We can hold on to that hope, can't we? Do you think working in somewhere like Glasgow, where levels of poverty are very significant, adversity is so obvious, does that help create potentially a moral case for people to do more for children?
I mean, I think Glasgow gets a bit of an unjustifiably bad press in all of this. Like other places, post-war, a lot of jobs disappeared and a lot of housing was knocked down and replaced by high-rise flats and so on. So there was a change in the culture and the the way in which society worked then. And I think hopefully we've moved through that a bit, but we still need to see the improvement in health and well-being. So yeah, I don't think there's anything, it's not as if there's something in the air in Glasgow or anything like that. I don't think it's like that. I think Glasgow, like many post-industrial cities, people began to lose jobs and begin to feel the impact of poverty. And Glasgow is a pretty thriving place now.
I would like to talk to you a bit about your role as the Chief Medical Officer, Harry. We've talked in this podcast to people who've played different roles, politicians, civil servants, charities. Can you just tell us a bit about what the role of the Chief Medical Officer is in terms of helping a government to think about children's policy, or what you made of it?
I think I was lucky because the health ministers that I worked with were clever and insightful and wanted to do good things. Sometimes you find they are a bit dismissive. They've got other things on their agenda and all that kind of thing. But that wasn't what happened with me. The question was, how do we do this? What's the mechanism? And we were lucky in as much as we had a senior civil servant and a medic working with us who had been to the Institute for Healthcare Improvement in Boston, and therefore improvement science became part of what we were trying to do. Now, it made a difference, and I think I was lucky to be exposed to that and to see how important improvement science is. And that's what I'm doing now. I when I left the CMO role, went to Strathclyde University, where they have a very, very powerful business school and computing and information folk, artificial intelligence expertise and so on. So it's applying that kind of thinking to a complex system that begins to change that complex system. So that maybe wasn't available when I was Chief Medical Officer, but certainly colleagues and I are trying to make use of it now.
Can you tell us a little bit more about what that looks like in practice? How does that improvement science and those different disciplines work?
The thing I really learned about improvement science was if you want to improve a system in which people are working flat out, don't tell them what to do. Ask them what they think needs to be done and then help them achieve that. Undoubtedly, that makes a big difference. If someone is feeling overwhelmed by a workload or whatever, and some smart aleck like me comes along and starts to tell them things that should be added to that workload, you're not going to get anything happening. But if you ask them, how could we change what you're doing in a way that fixes some problems and release some of your burden, then that's an important element of it. And as well as designing the system with the frontline staff very much in the driving seat, the other thing you need to be careful about is the data. For example, one of the things that we did was we instituted many years ago an improvement of science approach to the management of breast cancer in Glasgow. Differences across different bits of the city and so on. We looked hard at that and we got the clinicians to come together to work out what was happening. And many years later in the BMJ, we published a paper that showed that there was a significant improvement in breast cancer survival with that. But because we'd collected all sorts of data, we also showed there was a significant improvement in non-cancer survival in these women, that they weren't dying in such numbers of breast cancer, but they weren't dying of other things in such numbers either. And difficult to explain that. The only explanation we could come up with was that each of the clinical groups, we asked them to employ a breast cancer nurse who would interact with the patients. And what we think was happening was women would get a symptom, they'd phone up the nurse would say, I don't think that's anything to do with your breast cancer, you'd better go and get it checked out. And therefore they were getting early advice to go and try and fix other problems. So the data shows you if you're getting a range of different outcomes, and that's absolutely vital to collect that data. And the other thing is, if you don't collect the data, the managers of your hospital or health board or whatever will soon get fed up and say, all right, we're going to stop this because, it's costing us money or whatever. And if they're stopping something that is producing a good outcome, then that's a huge kick in the teeth for the clinicians.
Yeah, there's lots of resonance with things you're saying about the Sure Start story in England and the data showing those impacts, but long after the people had moved away from it. And I guess that's the specific challenge around early childhood, isn't it? That collecting data that allows that informs decisions in the right timescales is harder.
Yeah. The sort of Sure Start stuff, you might not see the positive outcomes for 15, 17, 20 years, and that's lost then. The learning is lost.
When you were CMO, there were others in the system who were also championing investment in early childhood. So we've interviewed for this podcast Peter Wanders of the NSPCC, and I know Matt Ford in Scotland was a champion for early childhood. Did you find those coalitions of different people across the system useful in influencing policy?
Oh, yes, absolutely. Because they would have different linkages into different parts of society. And as long as we were all singing from more or less the same hymn sheet, then that was fine. That was excellent. In fact, it was really good. They would feel good because we were supporting them, and we certainly felt good because we had positive support from a number of very good people out with the government.
As you got more senior in your career and in that CMO role, when you're working closely with government, was there anything that surprised you about how policy decisions were made? Was it the sausage factory? You should never see how it's done.
I wouldn't say surprised, but you would sit and you would watch, and I'm not necessarily talking about the health department here. If there was something on a number of other departments were involved and so on, you might see a different dynamic in the civil servants and advisors and so on in another area than you would see in the health area. And sometimes you could be frustrated because folk would take the view that, well, we're spending money on this, so let's stop spending money on it, let's stop it, and so on. And you would think, well, you don't know if it's not making any difference because you haven't been looking at it long enough and so on. But, it's a very complex arrangement, having lots of different ministries, lots of different politicians and senior civil servants together by and large in Scotland, everyone got on pretty well. I never saw any punch-ups.
And do you think the situation facing children in Scotland is different from the situation across the rest of the UK?
There will be differences in different areas, areas that are rural versus very high population areas of cities and so on. Children will be exposed to different stimuli in each of these areas. So, yeah, but I can't off the top of my head think of any huge political drivers of differences. There might well be a local authority that is not doing the right thing, but you would hope their Director of Public Health would spot that and tell them off about it, that kind of thing.
Do you think there are differences in how the governments in the different nations of the UK think about children or public health or the way they work?
I have to say, I interacted well with the CMOs of Wales, Scotland and England, and we tended to, all be on the same hymn sheet, by and large. Maybe the odd bit of disagreement, usually with England, but...
I noticed England was last on your list, Harry.
No, there were times when health service managers in England would phone me up or, I see you're doing this, what is that you're doing, and so we exchanged ideas pretty regularly.
Yeah.
And there were never any major disagreements that I could see.
That's interesting. We've got time for one more question, Harry, and I just wanted to ask you, what are the big questions about early child development that you still think researchers need to answer if we're really going to make a difference to children's lives?
How do you fix adverse events? I got to know very well a scientist in New York called Bruce McEwen, and you would guess from that name that he was very proud of his Scottish ancestry. And Bruce did a lot of work on brain structure and activity. And regrettably, Bruce died very early on during the COVID epidemic. But some of the things that Bruce was doing, I think, would allow us to repair the damage that was done in early life. And we just need to do some research on that. And, he died before he could bring that research to fruition. But I think we need to pay attention to the science behind this and try very hard to repair that damage. It was always taught to us that if a brain was damaged, you couldn't repair it. That may not be the case.
Thank you. Some hope there. Hopefully Reese's research will be continued and built upon.
Yep, I hope so.
Harry, thank you very much for taking the time to talk to us. It's been really interesting to talk to you. I've really enjoyed it. Before we go, I'd just like to remind our listeners that if you enjoyed listening to this conversation with Harry, please do check out the other podcasts in our series, which you can find on whichever platform you get your podcasts. And please tell your colleagues about the Mobilise podcast too. Mobilise is a mini-series created by the Centre for Research on Play in Education and Development and Learning here at the University of Cambridge. For more information about Pedal and to access our wider resources, please visit our website, pedalhub.net. Thank you for listening.